Okay, I think we're going to go ahead and get started, guys. So first off, thanks to everybody who registered and is attending. What I heard was that there were a few hundred registrants, which is pretty amazing. I think that speaks to Dr. Newby's presence, because if he can get half the SCCT annual meeting to join on a webinar, that says a lot about what he's going to talk about today. So, I'm Jim Min, and it's my pleasure to introduce Dr. David Newby. He is a professor of cardiology at the University of Edinburgh. And in my mind, he's like a true clinician, physician scientist. And the reason I say that is that if you look at the research that he does, about half of it is really intended to change clinical practice through large-scale clinical trials. And then about half of it is really like translational research that tries to look at sort of coronary and cardiovascular pathophysiology using imaging. So truly combines the science with the clinical. In doing so, he's published more than 600 peer-reviewed publications, and he's served as the principal investigator on numerous multi-center clinical trials that include PREFER, which looks at sodium fluoride, SALTIER, which looks at aortic stenosis, dual antiplatelet therapy. And I think for at least this audience, his claim to fame was in performing the SCOT-HEART-1 trial, and now currently the SCOT-HEART-2 trial. And in that vein, I think that SCOT-HEART-1 trial was the most contributory piece of scientific evidence to the field of coronary CT angiography to date. So kudos to Dr. Newby, and David, it's a pleasure to have you, and I'll turn it over to you.
Well, welcome everyone. My name's Dave Newby, and I'm here to talk to you about atherosclerosis and how it can guide diagnosis, prognosis, and clinical decision-making, hopefully in the expectation of improving patient outcomes. Here are my disclosures. Principally, I should flag up I'm the chief investigator of the SCOT-HEART trial, so you'll have a rather biased view about CT, but hopefully we can have a few discussions later about the value of CT imaging in the coronary arteries. Okay, so I've been asked to talk about these four key themes. So I'm going to start off by talking about the diagnosis with atherosclerosis imaging. Now, obviously, classically, if patients have symptoms, if they're worried about having coronary heart disease, they'll go and see a clinician. They often have non-invasive functional testing, ischemia testing, and then where positive, go on to have an invasive coronary angiogram. And that's the sort of classic standard paradigm. But actually, if you look at the data, this is data from Europe, European Angina Survey. What you actually find is ischemia testing doesn't really make a huge difference in terms of impact, in terms of events, whether it's positive or negative. What is crucial is knowing whether you've actually got coronary artery disease, so actually seeing whether you physically have got coronary artery disease. And I think that was really sort of some of the spur on to actually use CT, which is currently the best way of non-invasively determining whether someone has coronary artery disease. So we set up the SCOT-HEART trial, where we asked the question, if we layer on top of the current clinical assessment, the CT coronary angiogram, does it affect the diagnosis? Does it affect investigations and treatments? And ultimately, does it affect outcome? And at the beginning of the trial, we pre-specified coronary heart disease, death, and non-fatal MI as the main outcome we were interested in. Now, just to rehearse some of the arguments, non-invasive functional testing, here I've used exercise ECG, which of course, perhaps is the least sensitivity for detecting coronary disease. You can see here an example of why ischemia testing sometimes has problems, because there are two things to highlight. Firstly, yes, if it's abnormal, if the test is abnormal, then you're highly likely to have the condition. But often you miss a lot of obstructive coronary artery disease, so the sensitivity is poor. Laid on top of that, of course, is non-obstructive disease will never cause, or should never cause, ischemia testing to be positive, and so you're going to miss that. And there's an awful lot of non-obstructive disease about, and that's something we'll come back to later. So really, ischemia testing is a bit on the back foot from the start. Now, when we layered on a CT coronary angiogram, this actually was the primary, initial primary clinical endpoint of the trial, because it was testing diagnosis. If you actually asked the clinician, were they more or less certain after the CT whether someone had coronary disease, they were a lot more certain. And were they more certain about angina due to coronary disease? Again, they were a lot more certain, twofold more certain about it. But interestingly, what did differ was you diagnosed more coronary disease, but actually you diagnosed less angina due to coronary disease. And that's probably because the CT gave you the confidence to say, no, you don't have angina. Whereas if you're uncertain, you tend to err on the side of caution and perhaps overtreat people. So we saw a slight divergence there, more coronary disease, but actually less diagnosis of angina due to coronary disease. And actually, was that just the clinician being stupid? Was it true? Well, actually, the arbiter of invasive coronary angiography, those that went on who'd had a CT to invasive angiography, they were much less likely to have normal coronary arteries. So the CT clearly was very good at its negative predictive value. It's showing that you didn't have coronary disease. But conversely, of course, that meant the people that got into the cath lab were more likely to have obstructive disease and therefore actionable disease in terms of coronary revascularization. So it certainly seemed to pull through from that diagnosis. Now, since SCOT-HEART trial, there have been many trials, in fact, and we took part with our SCOT-HEART data in this individual patient meta-analysis, over 10,000 people or so. And what you can see here is that CT performs extremely well. And if you're going for the diagnosis of obstructive coronary disease, it is very sensitive and arguably highly specific. But if you actually were to change what the question you're asking, i.e. cross out obstructive disease and just say, can you detect coronary disease? I think that specificity would lift well into the mid 90s, if not higher. So it really just depends on what question you're asking. But classically, we're interested and slightly obsessed, in my view anyway, of looking for obstructive disease. But CT performs probably as better as well as any other test, actually, in terms of its performance. And of course, because of that, the international guidelines are now changing. European guidelines certainly give CT coronary angiography a class 1 indication for the diagnosis of coronary disease. It can't let go of non-invasive ischemia testing. And I think there certainly is a role for non-ischemic testing, usually in people who've already got a diagnosis of coronary disease, so you know they've got coronary disease. I would argue if you don't know, then a CT coronary angiogram is best, and that's certainly what the NICE guidelines recommend, is CT is the first-line test of choice in people with possible angina. Now, interestingly, the ESC guidelines suggest if you have a low clinical likelihood, and by that, certainly previous guidelines have suggested that's 50%, so less than 50% should have a CT. If you've got a high pretest probability above 50%, you should have a non-invasive ischemic test. And actually, they've gone back and revised their pretest probability tables because it was recognized they were overestimating risk. And this is now the standard table that you have on the right-hand side. And you can see that actually, by default, CT is the test of choice because virtually everyone, with the exception of a typical typical symptoms of angina in a man over the age of 70, should have a CT angiogram, and arguably it's pretty borderline even in that latter group. And so the performance of CT really is really quite striking in that regard. So I think in terms of diagnosis, actually seeing whether you've got coronary artery disease is key and absolutely important for the diagnosis of the patient. And really, there's little that actually beats imaging atherosclerosis with a CT coronary angiogram. What about prognosis? Well, it's of course ischemia testing historically over the last 40, 50 years has been held up as a paradigm of risk prediction. That's its major strength. Not only can it tell you whether you've got ischemia, but the more ischemia you have, the worse you do. And that has been one of the cornerstones of modern cardiology. But actually, now that CT has come along and we start to pick that apart, it's actually perhaps not on such a strong foundation. Again, this is data from SCOT-HEART. Again, this is exercise ECG I've shown you. In SCOT-HEART, whether you had a CT or not, 85% of the patients actually had an exercise treadmill. And what you can see on the right-hand panel is risk prediction of that exercise treadmill by whether the treadmill was positive, equivocal, or negative. And what you can see that, yes, it does predict risk beautifully. But ultimately, because the majority of people have a normal exercise test, over half of the MIs have a normal or equivocal exercise tolerance test. So only a third of the MIs are actually in the positive group. So actually, you're missing a lot. Whilst the specificity is good, the sensitivity is poor. Now contrast that with CT on the left, and you can see that CT has a much greater discriminatory capacity. 40% of people had a normal coronary angiogram. As you can see, that's an 11-fold lower risk than if you had obstructive disease. But also notice that the non-obstructive disease has actually quite a high risk as well of events. And of course, a functional test, as we've already mentioned, has no chance really of identifying non-obstructive disease, because by definition it's non-obstructive, so it shouldn't give ischemia, so you're not going to find it. And yet here are all these MIs. So over half the MIs were caused by disease that was not obstructive. Now you might say this is Scott Hart, and this is an exercise treadmill. If we look at the PROMIS data set, another big trial, 10,000 patients, and there is a head-to-head comparison between a functional ischemic test and CT to look for atheroma. You find exactly the same findings as I saw, and actually if I flick between the two, you're hard pushed to see any difference between the graphs here. And of course the functional test here was predominantly ischemia testing with nuclear imaging. And again, the majority of MIs occurred in patients who had a normal functional ischemic test. And the corollary was that CT had a much better discriminatory capacity. Again, a similar hazards ratio here, a 10-fold discriminatory between normal and severely abnormal tests. So really, whilst functional testing has the strength of prognosis, actually seeing whether someone's coronary disease is so much more powerful. Now, of course, we've been talking about obstructive disease, and most of our obsession in the past is to identify obstructive disease. But now we have CT. Not only can we see whether there's obstruction, we can also look at the plaque characteristics, and this is fundamental to risk stratification. This is one of the seminal works by Motoyama, looking at CT plaque characteristics and comparing patients with acute coronary syndromes with those with stable angina pectoris. And what you can see is that those with an acute coronary syndrome have plaques that are positively remodeled, and they're plaques that are low density, possibly with spotty calcification, but much less large calcification. Because of course, if your plaque's heavily calcified, it's hard for it to rupture because it's got a nice firm, rigid cap to it. The spotty calcification probably identifies necrotic plaque that's trying to calcify and wall it off, but it hasn't got there yet. And of course, the non-calcified plaque is often lipid rich and again necrotic. So we can see all these potential features that identify risk of events. And certainly when we've looked at it, it's been also seen in PROMIS as well, that if you have adverse plaque characteristics, your event rate is much, much higher than no adverse plaque. And on the right-hand panel, just for reference, is the obstructive disease element. And of course, to be obstructive, you have to have a large plaque burden. You have to have positive remodeling that's failed. You have to have a lot of lipid in there to get to the point where you have an obstructive plaque. So these things are actually a little bit interrelated. So one thing you can do is actually get more into the nitty-gritty of, rather than just saying these plaques look like they're positively remodeled and they look like they've got necrotic cause, actually quantify it. And there are lots of potential ways of doing that. Here I'm showing you some data from, we're using one software package, AutoPlaque, but there are many, as you know, on the market, and clearly, obviously, has a wonderful package to do this. But here, if you actually get into the nitty-gritty of quantifying plaque, then you can get even higher level of prognostication. And when we've looked at this in the Scott Hart, actually, a lot of these factors that we know are risk factors are co-associated. So calcium score, risk score, area stenosis, all of these things do correlate with adverse plaque characteristics, and in particular the low density plaque, which of course is the lipid-rich necrotic core plaque that is linked mostly to adverse events, and that really is quite powerful. So actually, you know, we talk about stenosis being an amazing predictor of events, and it is, but it's probably because of its co-association with a large plaque burden and also adverse plaque characteristics. And certainly when we've looked at this in Scott Hart, and we used modeling and adjusted for everything we could think of, including stenosis, calcification, etc. The one thing that stood out as a big predictor of future adverse events was low density plaque burden, outperforming anything else. So really, I think what we're now at is not only obstructive disease, we're going beyond that to talk about the characteristics and the burden, the volume of plaque that these patients are having as being the best predictor of outcome. Okay, now we're going to move on to management from prognosis. Does it make a difference to how we treat people? Well, certainly we found that if you use CT scanning, it does change your treatment. And as I've explained to you before, it increases the diagnosis of coronary disease, but arguably reduces the diagnosis of angina due to coronary disease. And so treatments do change in line with that. And of course, things go in both directions. So because we've got an increase in coronary disease, yes, some preventative therapies were stopped in those were found to have normal coronary arteries, but more were started in those because we found a lot of undiagnosed coronary disease. And the reverse was true with anti-anginal therapy. And whilst we did start some anti-anginal therapies, we also stopped a lot more because the diagnosis of angina due to coronary disease was reduced. So yes, it does make a difference to the preventative and symptomatic treatment of our patients. And just to show this graphically, this is just showing you the preventative therapies, which not only change from their baseline assessment, obviously at baseline is before they have the clinical assessment. And as you can see, after the clinical assessment, the CT arm is associated with more antiplatelet statin therapy, which persists out into the longer term. And actually, when we look in the group that has CT, people are much more likely to be recommended or be on therapies when they're found to have coronary disease. So you can see the cardiovascular risk across the x-axis there up to 30%. And actually, it's interesting to see that even when you've got a high risk score, a lot of people don't take statins. So they're the non-coronary artery disease group are below 50%. But in those that are told that they have obstructive disease and non-obstructive disease, you see a much higher compliance with therapy. And that's particularly important for those where risk scores might not otherwise recommend therapy. So some of these people had, less than 10% risk score over the next 10 years and wouldn't be given therapy, and yet they'd be missed and at risk of secondary events. Sorry. And of course, the final thing is CT angiography. Now, one of the criticisms of CT has been that it encourages extra coronary revascularization. And I don't think we should apologize for that. If CT is more accurate at finding the disease and treating the disease, of course it's going to increase revascularization. That's its job, surely. But what is interesting is once a year has passed, so the extra revascularizations that were triggered by the CT have passed, what you see beyond the 1 year is actually an inversion of that. So people who didn't get a CT have more revascularization than those that did have a CT beyond 1 year. And of course, there's two reasons for that. Firstly, the people who had a CT got their angioplasty earlier because it was found earlier and were treated more appropriately. And of course, secondly, they were started on secondary prevention, so their atheroma didn't progress, so they didn't then subsequently come back with further events needing treatment, whereas the standard care group did. So it's no doubting that management is changed by CT, people action it, and of course, if you know that someone's got coronary disease, it makes things so much easier to make that decision-making process. So finally, we come to the clinical outcomes. Does it affect clinical outcomes in our patients having done all of this? Well, primary endpoint of the clinical outcome segment of the trial certainly showed that your chance of having coronary heart disease death or fatal MI, another terminology, or a non-fatal MI is reduced by about 40%. And people often ask, well, what's the distribution of that? Well, if we look at non-fatal myocardial infarction, it's pretty much the same hazard ratio reduction. And if we go to mortality, of course, the number of deaths are modest. So you can see 4 versus 9, but the hazard ratio, if anything, is higher, but not statistically significant. And we're hoping to perform 10-year outcome study to see whether we can see a cardiovascular mortality benefit. But nevertheless, it's very consistent with what we see with the myocardial infarction. Another thing I always like to point out is this little anomaly just at the beginning of the Kaplan-Meier curves there. You can see that the event curves overlap. And of course, CT is not a treatment. It doesn't stop you itself preventing a heart attack, but it's identifying atheroma that is then actioned. And so there is a delay, and in the Scott Hart trial, it took us 2 weeks to actually get the CT scans and then time to actually draw the attention to the result. And actually changing prescriptions took 6 to 7 weeks to actually happen. So there was a delay, and that's why those curves are overlapped. And if you sort of ignore that overlap and then do a landmark analysis, then actually you're halving the rate of myocardial infarction. So for me, this gives some nice validity. It shows that the two groups were well matched, and CT doesn't change anything until the clinician acts on the fact that this patient's got atherosclerosis and needs treatment with statins, needs aspirin, needs an intervention, needs to change their lifestyle, they need to stop smoking, and so on and so forth. Now, the PROMISE trial, as already alluded to, a similar trial performed in North America. The difference there was no layering of CT, but this was a head-to-head comparison. But I also want to draw your attention to the fact that the endpoints were very different. And if you look at the primary endpoint of the PROMISE trial, it has all those components on the right-hand side of the screen. And I think this was part of why the PROMISE trial had a different outcome to the SCOT-HEART trial, because the endpoints were actually importantly different, and particularly the hospitalizations for unstable angina. So I think if you increase the diagnosis of coronary disease, that does increase anxiety of people, and they may want to present more to hospital with symptoms. And notice that's hospitalization for unstable angina, that's not myocardial infarction. And the days of high sensitive troponin, I think that did create some noise in the endpoint. There's also some noise from the complications of cardiovascular procedures, which actually were quite few. But nevertheless, I think this underlies why it's different. And if you go into the supplement of the PROMISE trial that was published, and you used an endpoint that's very similar to SCOT-HEART, they didn't have cause of death, so you can only have all-cause death. But if you actually look at the pre-specified 12-month analysis of death or non-fatal myocardial infarction, actually it's very similar to SCOT-HEART when it had its early 2-year outcome data. So both of these were roughly 2 years, and you see their outcomes are almost identical. So whilst people say there's a difference, PROMISE trial was neutral and SCOT was positive, actually they show pretty much the same thing if you look at the same actual outcome measures. And indeed, there have been further studies and meta-analyses performed, all showing consistency of effect. They're all to the left-hand side of the line, the Unity, and the observational data at the bottom of the screen there in Denmark certainly suggests that a CT coronary angiogram is associated with much less myocardial infarction. So seeing is believing. If you see that you have atheroma, you act on it. If you see the extent of the atheroma, you intensify your treatment based on what you see. And so it really is seeing is believing when it comes to treating and diagnosing, managing coronary artery disease, which then improves the outcome of the patients. So that's my walk through how actually seeing atherosclerosis in your coronary arteries changes how you diagnose, how you assess the prognosis and risk, how you manage your patients, and ultimately improve their outcomes. And as an overall summary, these are the sorts of figures that we're really seeing. So seeing is believing. Identifying coronary atherosclerosis with CT angiography is key. We're now moving towards actually going beyond just assessing stenosis to look at the overall burden, and particularly the higher risk characteristics, which I think are going to shape our management even further in the future. Thank you very much for your attention.
First of all, thanks for such an amazing talk. Like, I mean, in a matter of 20 minutes, you summarized so much in the literature. You know, I just wanted to start off the questions I guess like in hearing you speak, like, I guess what occurred to me was that, you know, the way we've done things essentially is to check risk factors, do risk scoring, and then we send patients home and we wait for them to come back with some chest pain or symptoms at some point. And we've done ischemia testing to look for stenoses and ischemia. So in thinking about that, like, risk factors are actually not the disease, right? They're surrogate markers of disease, as we all know. And symptoms aren't disease, they're signs of disease. And ischemia and stenosis aren't diseases either, they're sequelae of disease. And so as you were speaking, I just thought to myself, like, for the last 70 years, we've actually never measured the disease, the primary disease process. And one sort of extreme analogy that went through my head is that, you know, we get GI bleeds from colon cancer, but nobody's checking hemoglobin as a tool to figure out whether or not somebody has colon cancer or not. And I guess the other thought that I had, and then I have a question for you, is that, you know, we've spent 15 years really focused on CT to guide who should go to the cath lab, who should get revascularized. And, you know, what I heard from your talk today is like low density dark plaques are bad. We know from a body of literature that the brighter the plaque, the more stable it is. and that from a series of medications and lifestyle interventions that all of those medications, diet, exercise, they turn dark plaque bright over time. And that's associated with a reduction in MI. So my question for you is like, you know, we've been so focused on the use of CT to guide who should go to the cath lab in a way that would reduce MI, but should we be thinking about CT as a method of monitoring therapeutic success to prove that we have actually achieved cessation of the atherosclerotic process and stabilization of the plaque through the conversion from dark to bright? And be curious to your thoughts on that.
Yeah, thanks, Jim. And I completely agree with you. The more that I've done this, I mean, we were all brought up on ischemia testing and a way of avoiding doing invasive cath, which at the time was, you know, had potential, you know, lethal, unfortunate side effects. And obviously we've got better at that. But actually, what we have now is a technology that, as you say, that can actually tell you how much plaque you've got. What is the burden? What is it looking like? Has it got high risk characteristics? What's going to happen next? And that is, for me, you know, no other imaging modality, it's not even invasive angiography, right? Because that can just tell you about stenosis. It's actually very two-dimensional. It doesn't tell you about the wall. And actually, you know, in some senses, you know, when I talk to cardiologists and my children, sometimes boring them to death, you know, this is Dad, this is not a particularly wild idea, is it? I mean, really, you're just looking how much disease you've got. Isn't that obvious? And of course, it is obvious. And we've been chasing lots of surrogates and lots of things. And we really need to now knuckle down on volume of plaque, type of plaque, and plaque characteristics. And what you're suggesting there in terms of follow-up scans, absolutely, I think that is certainly on the scheme of things. We've seen that certain plaque characteristics do predict future events downstream. We need to intervene upon those. And these plaque characteristics are in the mechanistic pathway, right? These are low attenuation plaques. These are lipid-rich plaques that are going to rupture. They're at risk of rupture. And we need to turn them back to the hard, calcified, firm plaques that aren't going to cause any trouble. Of course, we don't have trials to know how you can intensify therapy with CT. But that is certainly something that we need to think about for the future. Absolutely, you know, how often should you do it? What are the interventions? What are you going to escalate? What are you going to do differently to manage that? And I think this is really key to how this technology is used going forward.
Great. Thanks, David. And then there's a few questions. I'm just going to read them out, like, so that everybody can hear them. But one of them is from. Are there any proven therapies for mild subclinical atherosclerosis? Would you use moderate intensity or high intensity statin for calcium score of 10, for example, and essentially normal lipids?
Yeah, I mean, that's a tough one. I think the straight answer is no, there isn't, of course, but we do need to think that through. I actually got a huge criticism for Scott Hart in that because we mandated that you did something about what you found. So if you had plaque, non-obstructive plaque, and you had non-anginal chest pain, we insisted that they got started on aspirin and a statin. And I had various people criticize me saying, oh, where's the evidence base for that, whatever. And I preferred to the simple thing, well, you've got disease, right? I mean, does it matter? Yeah. You know, we've been treating people with high cholesterols and hypertension for decades, but that's not actually a disease, right? It's a risk factor for the disease. And here we've got the disease. Why would you even question me? And actually, I've stopped using the term primary prevention, secondary prevention now. I just talk about prevention, because I don't know what that means anymore. Because, you know, you see somebody that's got mild disease, is that primary prevention or is that secondary prevention? Now you can say, well, they've not had an illness, but they're going to have one if you don't do something about it, right? So let's just let's treat the dis-ease of the artery and treat the plaque and manage it. So yes, I think, you know, we do have a slightly graded approach. I think when someone's got a tiny little nick of a plaque, do you give them an aspirin and a statin? Probably not, just a statin. As soon as you start to get into more atheroma, I throw in the aspirin. And when they've got really widespread atheroma, then I start throwing an ACE inhibitor. So that's my strategy. In terms of the level of the statin, I'm pretty chilled about that. I think once you've got some disease, hit them with a statin, get the cholesterol down, and I would probably go to target on that. Is there evidence-based? Well, there is some evidence for that, but not based on the CT appearance. But it seems logical and intuitive, and that's certainly what I do.
Yeah. Okay. I think that that's great. Like, we use this phrase continuous prevention, but I like just prevention. It's simpler and it gets to the point. Just a few more questions for you. Sam Wan asks, are there any proven therapies for, oh no, actually, I think that was Sam. So next one is, can CTA be used to judge the effectiveness of therapy, such as statins, in treating atheroma?
Well, I certainly think you can see the characteristics evolve, and in terms of success, you can see the plaque characteristics become less adverse or more adverse. So you can see that. Whether that translates into downstream events, our observational data would suggest that it should. Of course, what we've not done, and in some senses, it's amazing that you've got an adverse plaque at baseline, and then 5 years later, it's predicting an event. I mean, you know, plaques do change, perhaps not as quick as we think they do, actually. And that comes down to how often we should keep doing this. I think you know, how it might change how we manage them, the intensification of therapy, etc. These are sort of intuitive things that we should really consider. But ultimately, what is the perfect goal? Are you going to start laying a PCSK9 on top of a statin if you've seen aggressive disease? That would seem logical. We know that these drugs do add value on top of statins if you're not getting what you need. Should that be guided by your cholesterol? Arguably, I'll be more keen to put someone on a PCSK9 if their coronary anatomy got worse than whatever happened to their cholesterol. So yes, I would definitely be in that camp.
I think you highlight something really important. Like 5 years ago, this was sort of a moot discussion. We just essentially had statins and Zetia and some low-dose aspirin, and now we've got the icosapent ethyl, PCSK9 inhibitors, GLP-1s, SGLT2. I mean, there's just so much in our armamentarium that we can now sort of fine-tune and custom tailor treatments. Just a few, I know we're running out of time, so I'm just going to go through these quickly, David. Do you think CT will replace the demand for invasive intravascular imaging such as IVUS or OCT?
Yes, that's an easy one. I think I've done research with IVUS over the years, and NERS IVUS and OCT. You know, these things are good for non-obstructive disease. Perversely, you know, you got an obstructive lesion, you have to angioplasties and get the bloody images. I mean, what's the point? CT can look at all of these things, and it has got sufficient resolution to give you these things. And of course, you can do that in all 3 vessels simultaneously in one simple procedure. If you're going to do 3-vessel IVUS, you're only looking at the proximal vessels. They've got to be non-obstructive. I'm not sure how helpful that is, because unless you're committed to revascularizing these people, which often you are by the time they're in the cath lab, there are all these nuances. And certainly my practice has changed. It's a bit radical, I know, but I will do a CT. And if they've got 1 or 2 vessel disease, and I'm an interventional cardiologist, I want to put stents in, that's my job. But I don't take them to the cath lab if they've got 1 or 2 vessel disease until I've really tried them on medical therapy. And unless they don't want to take the medications and they're worried about it or everything, I will persist and persist with trying to manage it with optimal medical therapy. And often you succeed very nicely because they're not going to get a prognostic benefit from taking them to the cath lab, right? So you've got that reassurance, and that's what ischemia taught. You know, if you didn't have a left main, you've got time. And I think 3-vessel disease is certainly worth doing as well. But CT does change how quickly you take them to the lab and how much you'd like to just sit on them. And I'm certainly not a great fan of IVUS or OCT, just for practical reasons, and also for the fact that actually the most severe disease you can't study. CT gives it you all.
Got it. Like, yeah, and then a lot of people use this term 3-vessel IVUS but it's not really 3 vessels. It's like the proximal 2/3 of the vessel, and it doesn't include branches. And I think what we've heard is this term called whole heart imaging that CT is allowed to do. Just 2 last questions. Would you intensify your therapy when you find just high-risk plaque without stenosis? And if yes, what is the target for our intensive therapy?
Yeah, I think that's a discussion slightly with the patient. I think I don't care about obstructive versus non-obstructive anymore. Obstructive, I put in the symptom bucket. So if they haven't got symptoms, I don't worry about it. And if they're non-obstructive and they've got high-risk plaque features, I will certainly want to make sure that they're on good standard medical therapy, and then have a conversation with the patient about what they would like next. And some patients are quite happy just to go on the standard approach. Others will worry about it. And that's where you could potentially then talk to them about escalating therapy. again, I'm slightly, you can, the cholesterol level is a good surrogate for the treatment that you're giving to see whether it works, but whether it comes to the clinical outcome, it's inferred. And then we get into discussions about the particularly anxious patient that might want to follow up CT in 5 to 10 years time, that sort of scenario. And that's getting into uncharted territory, of course, but it's not an unreasonable thing to do in people who are very anxious about this.
Okay. Yeah, I think that's a great answer, David. And then the last question is, with the results you have just shown, do you think I should talk to my boss to ask him to buy a new CT to perform CTA?
That's the best question, and it's the best obvious
Dr.
answer.
Delgado.
Yes. Why not? Why not?
Okay.
Get one. Go get one.
All right. Well, David, thank you so much for all of your help and for giving us this amazing lecture.